guys hear me? Nice. Yeah. Okay, good. Yeah. Okay. All right. Cool. Thank you. Thanks for showing up. I know it's getting a little bit later in the day, so I definitely appreciate your dedication to learning more stuff. I will say right off the bat, before we get into this, that this syndrome, this disease, for some reason, or maybe it's not unexplainable, but for some reason, vets have lots of opinions on this, which are all great. So just realize that when I'm talking about this as a boarded surgeon, it's my own experiences. There are folks in this room that have done these procedures way longer than I have, and there are folks who feel strongly about doing or not doing certain things with these animals, these dogs, right? So I actually recognize that. And with that being said, I love all perspectives and opinions on it. It's a lot of fun to see what other people are doing or have been doing for these cases, because we can all learn from it. You don't have to be a boarded surgeon to tackle these cases, right? So I want to make sure that's very clear, because it gets a little passionate sometimes, which I love, but we want to make sure we also keep it professional as well. I do recognize that. So I'm Dr. Shadia Rakich, I'm a board-certified surgeon. I do want to thank VetScalpel for sponsoring this, and the proceedings, that if you don't have them yet, you will in the near future, has a whole host of information. And one of the reasons why I love this company is because we underutilize laser. So we'll get into that too, because it's an inherent part of this disease. But thank you for sponsoring it. Please visit their booth 919. There are going to be questions about lasers that, as a surgeon, the intricacies of, they're going to know the answers to that I may not know the answers to, and you may have those questions. So I'll refer you to them if there's anything that I'm not sure about. I'm not going to mislead you, but thank you again for sponsoring this talk, and also providing you a lot of the images and videos here. For those who don't know about me, I'm Dr. Shadia Rakich. I graduated from Cornell University in 2006. I then completed my surgery internship and residency at Long Island Veterinary Specialist in New York. From there, I moved out to Las Vegas, where I was a staff surgeon there for a little bit of time. After that, I flew around the country performing surgeries, giving other surgeons a break, and then settled for a year in Silicon Valley, managing 3 hospitals in that area, being a surgeon on call, chief medical officer, 24/7, between the three facilities. After that, I moved to Los Angeles, became part owner of a hospital there, was the chief medical officer for 3 specialties there, internal medicine, oncology, and surgery. And then, since then, I've been operating Vet Triage as one of the owners, as well as the chief medical officer, which is a telehealth platform. If anybody wants to talk about telehealth, I'm more than happy to, of course. We've got a long outline to go through. Some of this stuff is going to seem quite rudimentary, and some will hopefully seem cutting edge. So we'll go through this complex but common disorder that we see in dogs. We'll define some of the attributes, talk about the pathophysiology, how GI disease relates to it, clinical signs, various diagnostics and interventions, and then talk about complications, outcome, and prognosis. I'll try to sprinkle in things that I've learned as a surgeon over time, maybe words of wisdom, let's say. But again, I'd love to hear anybody else's opinions on stuff. Feel free to ask questions or comment in real time. We don't have to wait till the end. Whatever you're comfortable with, I am up for. So there are many more different attributes to this disease process, and a lot of these attributes come out through the literature based on doctors, whether they're general practitioners or board-certified folks who are running diagnostics on these animals and learning more and more about them. This disease is complex, and we are going to highlight, of course, the most common aspects of this disease, but realize there's far more than this in the literature, which will be in the proceedings, because that proceeding is like 47 pages long. So there's lots of stuff in there, but I want to focus on stuff that's clinically relevant. The idea here is that your proceedings has minutiae in there that's very academic, but this is meant to be very practical and clinical. So hopefully you'll see that. Elongated soft palate, hypoplastic trachea, nasopharyngeal stenosis, stenotic nares, everted saccules, everted tonsils, and laryngeal collapse. And those are the big ones that we think about for these poor dogs, but that's what the main components of this syndrome is. So the pathophysiology is somewhat tied to the timing of developing these conditions. So for example, we tend to think that these dogs, because of their genetics, we breed them to be brachycephalic. They're cute and have nice personalities, but they have problems. And the problem maybe starts with the nares. So with stenotic nares, you already have that increase in airway pressure in the upper respiratory tract, which then translates to downstream. So as the airway resistance in the nares and nasal cavities goes up, that then, theoretically, hypothetically, maybe, results in the soft palate getting longer, larger, thicker, which then contributes to that increased airway resistance. That increased resistance then travels downstream. Now you're affecting the tonsils, the saccules, you're affecting lower airway, the trachea, bronchioles. All these structures in the airway are going to become affected because of what started out as maybe a simple nares problem. And so the pathophysiology starts off with the nares and then progresses as they get older, because they're born with this, and then other conditions might be primary, might be secondary, but we don't know. Some of them are not as clear, but anyway, nares, palate, saccules, laryngeal collapse, and then this is a more advanced laryngeal collapse in these dogs. So that's kind of what we think it happens with them. There are also abnormalities that we're seeing deeper, meaning outside of just a physical examination and like a sedated laryngeal exam and outside of radiographs, where their nasal turbinates are not normal. Here is a quote-unquote normal dog CT scan, and here is a brachycephalic. You can see the difference in the structures of the nasal cavity, the turbinates, the sinuses. It is vastly different. And when you look at them through scoping, you have nice open airways here in the nasal cavity, and then in these dogs, you have these abnormal caudal anomalous turbinates that form because of all the airway resistance. We think that happens from the nares, or maybe not. Maybe these are present at birth. It's hard to say, but they all tie in together. You can see the structure of just the face between these three brachycephalics. I mean, there's nothing going on here, right, with this pug. And then if you look at the lower airway, this is not a great view, but if you look at the lower airway, if you follow the trachea down, you start to see the trachea gets a bit narrowed until you get to the bronchioles. So the problem here is, do they have hypoplastic trachea? Do they have redundant dorsal tracheal membrane tissue? What is going on there? Is this primary or secondary, and the bronchioles being affected downstream? So that's sort of the idea behind pathophysiology. Some of it's clear, some of it's not so clear, but that's the idea. Is we try to define these diseases, these components of the syndrome, as primary or secondary, and so we have to tackle all these anomalies with these dogs. Then you have GI disease. This, in my opinion, is probably one of the least investigated portions of brachycephalic dogs when they come to you with airway problems, is we don't do enough of a deep dive into their history, especially with GI. And a lot of these dogs have chronic gastrointestinal disease for a variety of reasons. Most often, the sliding hiatal hernia is maybe the foremost issue for these dogs, because as we talked about, the increased resistance to the upper airway, and then transits to lower airway, that then affects the GI tract secondarily. So you end up with motility issues, esophageal reflux or esophagitis, and they frequently will have secondary GI problems. And so these dogs are prone to, I'm going to call megaesophagus, but this is the result of chronic esophageal reflux and esophagitis, not necessarily a neurologic disease. So, but you'll see megaesophagus or esophageal abnormalities in these dogs. You have fluoroscopy, you've got the hiatal hernia, and then of course they're more prone to having bloat, not necessarily gastric dilatation involved. You just know that some of these brachycephalics are not prone to GDB, but they will have gastrointestinal motility issues. And then, of course, we know brachycephalics are more prone to pyloric stenosis. Does that relate to all this? I don't know, but we see these problems in these dogs simultaneously a lot of times. So are they related, are they not? So we have to investigate GI disease further, and it will contribute to their prognosis as well, postoperatively. We're all familiar with clinical signs. The loud, stertorous breathing in brachycephalic dogs, pretty typical, stenotic areas. Sleep apnea is a problem for them as well. So physical examination, you're looking at the nares of these dogs and trying to figure out, do they need a repair or not. You would like to think, theoretically, if you were to fix the nares early on and that was the only problem they had, maybe we're going to fix a lot of downstream issues with these dogs, right? That's the theory there. So maybe you can get at them early enough and repair this before it becomes higher grade. Maybe you can help salvage the larynx, the saccules, the lower airway, core pulmonality, so cardiac diseases as well, GI diseases. So maybe if we're more aggressive as veterinarians and as surgeons, maybe we can save these dogs from having more severe downstream effects. Did you want a picture? Go for it. All right. So then the workup. So you have the clinical signs, you deep dive into history, not just for respiratory, but also GI, and you've got the physical examination, and you're like, let's run some radiographs. And so if you were to take skull radiographs, in some of these dogs, you can maybe see that the soft palate is longer and thicker than normal. Sometimes you can see it in relation to the epiglottis and see that the soft palate is exceeding beyond the tip of the epiglottis. You can also actually measure, this is in the proceedings, a ratio of the thoracic inlet to the tracheal diameter and decide whether or not hypoplastic trachea is present. That is different than collapsing trachea. Collapsing trachea is a dynamic process that we see in small breed dogs as they get older. And the Brachycephalics, they have literally a smaller lumen. That's a hypoplastic trachea. It did not form adequately. And so that contributes to the issue with airway resistance. And then, of course, these dogs are prone to not just cardiomegaly, but bronchopneumonia. So you're looking for that classic cranioventral distribution, a bronchogram, air bronchogram that you can see here. See that? See the airway, how clear it is? That's because it's around it, the pulmonary parenchyma is infiltrated with inflammation and infection. So this is pretty typical bronchopneumonia, cranioventral distribution. These are all things you're looking for to work up these dogs. Not everybody has computed tomography, but CT will outline the nasal issues, the turbinate issues, the sinus problems, and of course, look, we can actually grade these too. So caudal aberrant nasal turbinates is that's in the literature, and so that's something that contributes. You don't have to have CT to talk to an owner about this. You can say a lot of these dogs have this as well. You see a pug with a sloped face. There's not much going on there. You don't necessarily need CT to prove that, but you can prove it with higher diagnostics. And then, of course, laryngoscopy is going to be the final diagnosis in terms of trying to characterize this disease further, within the realm of what most general practices can do or are able to do. So laryngoscopy, we try to grade laryngeal collapse into 3 stages. The saccules become everted in stage 1. By stage 2, the cuneiform process, if you look at the laryngeal anatomy here, cuneiform process begin to get inflamed and contact each other, and then at the most advanced stage, you've got stage 1 and 2, and then 3 includes stage 1 and stage 2, and then the corniculate processes of the arytenoids begin to contact, and so you get laryngeal edema and swelling and erythema, and of course that's the most advanced stage of laryngeal collapse. So another picture here showing different stages of laryngeal collapse. There's going to be some level of subjectivity to this, but there's your grade 1 with everted laryngeal saccules. There's the grade 2, and then you've got grade 3. And so this will affect prognosis. So that's why, in theory, if you were to treat these dogs earlier rather than later, maybe you can avoid this secondary sequela. Lower airway scoping, if your hospital has this, or if you refer to a specialty hospital, they can look at the lower airway and see what the abnormalities that are there. As a surgeon, of course, I'm not performing these. Usually it's internal medicine that's going to provide this for me, but it's just part of the work. I'll be looking for bronchiolar collapse in these cases, because a lot of them will have bronchiectasis as well. So management. Medical management comes in all shapes and sizes, things like oxygen, sedation, and theoretically, you have these patients coming in, fairly critical, you need to anesthetize them or at least sedate them. You can perform your laryngeal exam at the same time. You'll have a suspicion based on client history and the signalement of the patient to work them up, and of course, there's a variety of things you can do. And these are both in cases that are non-emergencies, just you have a loud bulldog, all the way to they're coming in collapsed with an upper airway obstruction and everything in between. So whether or not you're dealing with a dog you need to anesthetize and intubate and then stabilize and go from there, or whether you're talking about a puppy who just had some slightly loud breathing, all this stuff comes into play. It all depends on your experience, what you have access to. I will make a couple of points here with regards to gastrointestinal motility drugs. I love metoclopramide, and of course a lot of folks nowadays are using Cerenia as part of their pre-medication or anesthesia protocol. I think it's great. One of the issues with these dogs, of course, is their GI problems. And when they're under anesthesia, they don't have the protective mechanisms they would when they're awake. So aspiration pneumonia and then the resulting bronchopneumonia from there is a problem for these dogs. And so I actually will try to either inject Reglan as a bolus or even have them as a CRI pre and post-operatively to help prevent esophageal reflux and aspiration. Oh no, so the reason why I mentioned here Convenia and Simplicep is because if I'm going to have antimicrobial coverage, assuming they don't have other comorbidities, and assuming they don't have like raging bronchopneumonia, if I do need antibiotics, I'm going to go for something that's pretty straightforward. It's either a once-a-day drug, like Simplicep, to minimize oral medications, or an injection that'll last 10 or 14 days. But again, these surgeries for these dogs are not considered sterile surgeries, right? But also we don't tend to think of them as being high risk for infection outside of pneumonia and comorbidities. So this is kind of up for discussion, but I want to mention them because if I'm going to use antibiotics and I don't need big gun antibiotics, I'm trying to do something that's a bit more convenient. And then of course, tracheotomies for those veterinarians who are comfortable with this. In order to bypass the upper airway, you may have to place one of these to help stabilize the patient and maybe even get it ready for surgery or at least transfer it to a surgeon. So that's a procedure that if you're going to tackle, I'd recommend tackling this on like a cadaver and see if it's something you actually want to dive into before you try it on a real patient. So I'm going to dive into laser therapy here, and the reason why I'm going to talk about the CO2 laser in a broader sense is as the owner of Vet Triage, I've talked to plenty of veterinarians who are really against telehealth. And it's amazing how strong the personalities are. Everybody from we love it to we think it's the devil and everything in between. And it seems to me as a surgeon who classically did not get trained much in laser surgery, it's one of those things where it's like, oh, I know it's great, I see the literature on it, but boy, I've been trained this way and I'm used to this. And we do that all the time in veterinary medicine. We are afraid of change. Telehealth, lasers, we are afraid of change. And so one of the points I want to make here is if you know a procedure has been shown objectively in literature and in folks' hands as being maybe a better way of doing things, we need to get out of our comfort zone as veterinarians. We do this a lot. And I'm sure it's the same on human side too. I'm sure they're also afraid of change. We are really bad at changing. And so with that kind of honest perspective here, I do want to dive in a little bit with laser and the fact that VetScalpel is sponsoring this. Sure, that has something to do with this, but also they have the best product out there for this stuff. And if you guys are doing brachycephalic surgeries on a routine basis, I encourage you to try another way of doing this. It's not as new as you think. We've been doing this for a bit now. So I'm going to touch on laser. It is in the literature. There have been comparison studies on this, and they're in your proceedings. So with the idea behind CO2 laser is to be in that sweet spot where you're not resulting in all that collateral thermal damage to the tissues. That's the idea. We used to have laser that had a more, let's say, broad spectrum temperature range, and that's why you'd see that cauterization. I remember seeing that as an intern and resident. And now the newer equipment have narrowed down this field to where you can have all the positive effects of laser and remove all the negative effects. And so that's why when you talk about brachycephalic surgery, it's impossible to not talk about laser. It's a key component to this therapy if you're trying to provide the best for your patients. For those of us who perform this surgery, actually, a show of hands, how many folks do brachycephalic surgery in their practice? Yes, nice, good. How many folks don't, but they want to? They're thinking about it. Maybe a couple of hands. Okay, all right, good. So we can only improve things from here, I take it. So this is the setup for brachycephalic surgery. Usually we start off with the nares, and there's various surgical techniques, and of course there's the laser, and you're going for before and after, right? So you want that nice open nares. You want to do it in a way that minimizes morbidity to the patient, has a quick recovery, but it's also cosmetic. It should look nice. And I frequently find myself doing one side and then doing the other side and saying, oh wow, I like this side better. Let me go redo the other one. But however it is your technique is, most of us will prepare the nares, and then we'll open up the oral cavity and figure out the laryngeal issues. And so this is an example of the laser versus the scalpel, and you'll notice here, of course, a stark difference between the bleeding profiles when you're talking about the scalpel and laser, but also how quick it is. And so this is kind of the nice thing about using modern devices to treat these animals is you can, easier surgery, quicker surgery, better for the patient, better for you. So you're not dealing with all of this, which those of us who perform this surgery are all too familiar with. If you can do something that's a bit quicker and cleaner, that's what you'd like to see. So that's the nares, that's your idea there. It's fix the problem and make it cosmetic, and also not contribute to morbidity and mortality for that patient, right? The palate is always a fun one because there are many, many different ways of performing this, and I was taught as a resident, what I'll call an old school way, the cut and sew method, where you're dealing with a bloody mess, and if you're dealing with a bulldog that's had this for years, we know that palate. It's thick, it's so difficult to get through, it bleeds a lot, and so having a post-op situation that can be quite scary with all the edema, associated with this, it's a problem. And yet these dogs need their palates trimmed. So you can go with the old school method, you can use something like a ligature device, and then of course laser, which we'll show. But those of us who perform the surgery, you've probably tried at least one, if not more, methods. And then the contraption to get these dogs in a good position, it depends on your setup at the hospital, you know. So this is the idea here with a ligature device, and those of us who perform it with ligature, you can see all the thermal damage that's associated with it. I have also dinged the edges, the palatopharyngeal arches, so that's of course regrettable. You don't want that. And these procedures sometimes don't work that well with really thick palates either, which can be quite difficult. So it is quick, but you're going to end up with a lot of collateral damage for these patients. And then here's another comparison now, old school method, laser. It's almost cheating. It makes it so easy, it's ridiculous. Look at that. Minimal thermal damage, I mean very, very slight, and no bleeding, whereas with the more conventional method of cut and sew, you end up with trying to balance the suturing part with the transection as you move along. And at the same time, don't forget too, these patients are inhaling, aspirating blood. And sure, you might think, well, it's blood. I mean, how bad can it be? Bacteria love growing in blood. And so bronchopneumonia is a problem with these cases. So if you can minimize it, we're already done this side. If you can minimize it, the bleeding, that would be great for you as a surgeon, for visualization, and for the patient's aftermath. So again, take into consideration, there's nothing else that's going to be as clean and as efficient as this. You just won't find it anywhere. And so that's what I think the standard of care is nowadays. We just have to jump over our fear of something new and actually dive into it. And so this is pretty cool because like one of the most common questions I get is, you know, where do you cut? And you know, you want to have it where the palate is maybe right at the tip of the epiglottis, maybe a little bit past it. You don't want to cut too short. Too short, of course, is disastrous. You can't really reverse it. There are isolated case studies of reversing it, but it's a lot of work and it's avoidable. So I get the question all the time, you know, how do you mark it? So what you're going to do is you're going to extubate the patient. Maybe you've got propofol or something on hand in case they start to wake up, but you extubate them and you lower the opening of the oral cavity so you get a more natural position. When you have the mouth open, the tongue pulled down, the tube in there, you've altered all the anatomy. You can't really tell where the palate should end relative to the epiglottis. But if you extubate them, let go of the tongue, close the mouth as much as you can to still get a good view. You can see the natural positioning, and then with the laser you can actually mark it. So you can actually cut along that line and mark it that way. That way, if you don't like where you're aiming for, you can adjust accordingly. So you can actually mark it and say, okay, this is where I want to go, and then go for it. So that helps a lot with this. So I find myself doing is I continuously reposition the tongue, and I've got the Al's tissue forceps in the palate, and I'm constantly letting go, back, letting go, measure, letting go, until I get the right. And then once you're ready to cut, then you re-intubate, open up their oral cavity, and then you can go for it because you've measured it as accurately as you possibly could. All right. One more plug, veterinarians love multi-purpose, and so you don't just have to use laser for airway surgery, you can use it for a variety of surgeries. Everything from neuters to limb amputations to mass removals. You can dissect fascia with it. It's very, very cool. So you don't have to just invest in laser just for brachycephalic surgery. You use it for outside body cavities and inside body cavities. So I encourage you to visit the booth and just talk about these procedures because it's a lot. There's a lot you can do with laser. It's really phenomenal, and it's come a long way since back when I remember it. All right. So now with the saccules. I've over time stopped removing these. It does seem to me, at least clinically, maybe based on most of the literature, that saccules tend to be a secondary abnormality from the increased airway resistance. And I'll see it sometimes in real time where if I fix the nose, fix the palate, and then reevaluate the saccules, they tend not to pop out as much. And so I've left some of these alone, thinking, well, if I fix the major problems with airway resistance, it'll maybe fix itself. And so I've had, knock on wood, I have yet to revise one where I have not removed them and then had to remove it later. It hasn't happened yet. But if you do have to remove it, of course, you can excise the saccules. That's going to be kind of at your discretion. And the last thing I want to mention in terms of this is more experimental stuff, is we don't have a good solution for hypoplastic trachea, we don't have a good solution for laryngeal collapse. Medical management, fixing the primary conditions are what we have so far. And so I've seen this done, and I've done this, where for severe cases that you fixed everything you could fix, you may find yourself in a situation where that dog is still in trouble, and therefore maybe a tracheal stent, maybe, although again, stents are meant for dynamic diseases like collapsing trachea, whereas hypoplastic trachea is not a dynamic process. So this is a salvage procedure. I'm not advocating this. This is a salvage. This is like you've done everything else and you're trying to do something else. And the same thing goes for severe laryngeal collapse. Can you do a tieback? Maybe. We've done tiebacks, we've done arytenoidectomies. It's a big maybe, but again, these are salvage procedures where you're like, okay, do I do a tieback as a last-ditch effort for this poor dog? We've done everything else, and I don't know. And so the way I characterize the discussion with pet owners with this stuff, I tell them, the way we're talking about here, primary and secondary diseases, I'm talking about the fixable and the not fixable. That's why I talk to pet owners about this. Here are the things I can fix if your dog has them. Here are the things I can't fix. And sometimes the things I can't fix are going to dictate the prognosis, no matter how good of a job I do with stuff that I can't fix. And that's a pretty easy way to break down in owners' minds, like what the situation is, because we know it's very complex. And then complications, we spoke about things like severe laryngeal collapse, bronchopneumonia, needing to alleviate their upper air obstruction. Maybe they need a temporary or a permanent tracheostomy, stoma. So these are all things to think about as well. Okay, outcomes. So keep in mind, with outcomes like this is similar to like lots of other disease processes that we see in veterinary literature. The numbers are all over the place. It all depends on what technique you use, what type of aftercare you have, what type of history these pets have. And so these numbers are compiled from either a number of papers that I've found or papers that went through a certain number of dogs and made it to a conclusion. So whether this resonates with your own experience, we'll see, but improvement is typically seen in the majority of cases, 85 to 100%. I would argue probably some of the lower numbers might be due to either gastrointestinal disease that went uninvestigated, or situations where the dog waited too long, or the pet owner waited too long, or we could have fixed something years ago, and now they're fixing it now with an 11-year-old bulldog that has all these other issues. So that may be some of it. Some of it also might be surgical techniques. Some of it might be also aftercare, either in the hospital or outside the hospital. But improvement is still largely positive. Mortality can range between 2.5% and 15%. And then based on clinical assessments and especially owner surveys, how do pet owners view the recovery? 6 months post-op, excellent in 65% of cases. 6 months post-op, good, 25%. By 1 year, half of them are saying, yeah, pretty excellent. And then the others are saying, moderate, it's good, and then poor, 2%. So this is still a large variety, and this probably reflects, again, what I said before with the improvement numbers, but also with the fact that this is a multifactorial disease, has multiple levels of abnormalities to it. So it's going to, and going based on owner assessment, it depends. I mean, what's considered excellent for a bulldog? We're talking about like no more snoring, or are we talking about like he's going on hikes? What's the barometer here for that? So I don't know. But overall, it seems that it is positive, so it's worth going into these cases, especially if the alternative is going to be euthanasia or something like that. If they're willing to dive in and you talk to them about it candidly, then there you go. And then the GI disease. I mean, this is a wide range. 66%, 91% will have resolution. So what I tell pet owners with GI disease is, your dog has a history of GI disease, you've told me that, and he's got maybe GI disease now, whatever. The goal here is to fix the airway issues, and then maybe secondarily we can either fix the GI issues or maybe improve them, and maybe that improvement comes with lifelong therapies. Maybe chronic antacid use, for example, or chronic modifications of how they eat food. Do you do dry or canned? Do you do meatballs or hand feed them or not? So the GI disease we need to investigate further, but there can be cases with resolution, but it can be varied. And so if you treat both, the GI versus respiratory disease as opposed to isolated, the combination that you tackle has a way higher success rate. So that's the idea here, that we can see through the literature and through my own experience, and hopefully yours as well, that treating the combination is very important. How many folks here do make it a point to talk to pet owners about GI disease in terms of getting a history and afterwards? Okay, yeah, we need way more. We need a thorough history for chronicity for GI disease because it does play a huge role with these dogs. Okay, so factors that affect prognosis. So perhaps we should cut these dogs earlier, and I always get a question, how early? And I don't know. So what I'd like to see, what's the folks that do operate these dogs, what's the earliest that you've jumped into brachycephalic airway surgery? Just yell out some ages. 8 months?
5 or 6 months, depending on that.
5 or 6 months, depending. Yeah. When? 8 months. Yeah. So under a year, it seems, right? And so it would be nice to see more literature on this. If you have a cohort of dogs that are cut early, whatever early means, let's say it's 8 months, let's say it's less than 12 months at least. What do we see downstream? 5, 10 years later, what do we see? And so that would be great. But maybe early surgery improves prognosis. Maybe younger dogs, I've seen mixed literature where it says younger could be good or older could be good. So it's a bit of a mixed bag there. But you would think that younger dogs have better prognosis because of less comorbidities. But laryngeal collapse, of course, affects prognosis, and the higher the collapse, the worse the prognosis. The presence of hypoplastic trachea, the presence of bronchopneumonia, the presence of other diseases like airway or GI, and then maybe traditional multi-level surgery affects the prognosis, maybe. And so I want to see more literature there if we as a community treated these dogs earlier and use interventions like laser, for example, to try and treat them, can we get less invasive, earlier surgery, and then improve the outcome long term? That would be, of course, the goal for everybody. And then, of course, I want to see literature on that, obviously. We need to see if that plays a role. Which, in one to bed, it's going to improve things. So some key points I'll make before we take any questions or comments we have. Client communication is key. That's exactly how I phrase it. There are things I can fix, things I can't fix, and I'm going to fix what I can. And hopefully that'll either resolve the things I can't fix, or maybe the things that I can't fix won't be so bad that it overshadows the stuff that I can fix, right? That's the unknown part of it. But at least the client understands there are things that are out of my control that your dog may have or has, right, based on diagnostics. And so that's how we get them you get them on your side. If things do go south, right, you explain to them there are things that I could control. Your dog had bad laryngeal collapse, bronchiectasis, and heart disease or whatever. And so these are things we have to tackle. So the repairable versus irreparable aspects. Keep in mind the gastrointestinal signs, and then of course tailor the surgery to the case at hand. Just because we can fix the things that are fixable, well, maybe we don't have to fix everything. And the saccules are a good example of that, at least in my own experience. You tackle what needs to be tackled for that patient. Not everything has to be handled right then and there, depending on the case, your own experience, the client, finances, all these things, right? All that plays a role with these dogs. Okay, so this is my contact information, my social media, this is my company. Thank you again for VetScalpel. Please visit their booth at 919. And any questions, comments you have, please. So the question is, what would be the earliest symptoms of gastrointestinal disease that you would see in relation to this? So for me, it's always going to be, it has been regurgitation, and that's a tough one, right? Because not every pet owner can see that. But if you ask the owners questions like, do you ever hear your dog hiccuping or burping? Do you ever hear like rumbling of the stomach? And I typically will blame that on some kind of motility issue, and maybe they're regurgitating silently and no one's seeing it. But that's what I tend to see as kind of early steps. When the owners do notice it, it's typically like, because these dogs love food, and so they eat really quick, and then it kind of comes up. Well, was that the dog eating too fast, or is that a motility problem? Was that related to like upper airway resistance, and combined with the GI tract, and then we regurgitated the food? I don't know, but that's typically what I see as first thing. I don't typically see as often like the overt like vomiting and diarrhea. It's typically loud stomach, maybe drooling, maybe they saw some burping up or some fluid production. They thought, whatever, he ate too fast, or he ran around after he ate and got sick or whatever. But that's what I typically see with that. Does anyone have a different experience with what they typically will see? Yeah, that's typically what I tend to find with these animals. Yeah, it's the regurgitation part of what's going to happen.
So, then talking to clients, what do you
So the question is, sometimes when you present this situation to clients, they might be resistant to what you're recommending, right? And this is with any surgery, right? And this is with most things that we do as practitioners. So number one, it's like, what's the resistance? You know, is it financial or not? You know, or is this more of a, well, I just don't think it's a big problem right now, doc. He's a 6-month-old puppy. He's so happy. You know, why would I do anything to him, right? Whatever else, you know. We know the downstream effects of these animals. We know they're going to develop GI disease, other airway disease, heart disease. It's going to be a big problem. And we also know, just like other diseases, if you treat them later, it's hard to control later. It's hard to be more successful later on. And maybe right now, price-wise, financially, way cheaper, just fix some nares, maybe some palate resection, and we're good to go, as opposed to like dealing with higher diagnostics and referral, and now we're dealing with an intubated patient post-op who's got fulminant pneumonia and all that stuff, right? So it's like any other disease. You tell them, it's cheaper and easier now for the pet if you were to tackle this now rather than the future. But the problem is, and this is why I've never liked triple pelvic osteotomies for hip dysplasia in younger animals. You're taking a dog who looks pretty normal. You know, maybe they have some suggested abnormalities of the hip, but they look pretty normal. And now you can do a major surgery to the pelvis. All you can do is screw that up, right? Like they're not going to look any better than they look right now. They're walking pretty normal. You're doing a preventative measure. So are you going to take a dog who's just a little bit loud when they snore, but it's kind of cute, and do all this stuff, and then you have complications, and the pelvis is like, what happened, right? So you have to be candid with them, but that's how I would tackle. You compare the future, which might be really ugly, compared to now, both financially and medically. Other questions? I saw someone else's hand. Yes?
So to answer his question.
Yeah.
And a little bit on your question earlier, how we really do these. I see lots of them. The practice that we have. And when I see these Brachycephalic puppies, I see if they'll breathe through one nostril easily, and if they won't, I set them up at that time. That we'll see how these develop. But it is an indicator to me when they can't breathe through one nostril comfortably, that almost all of these puppies, their dogs need something at some point. That's my arbitrary thing, but it makes sense.
So what Doc is saying is that he's quite seasoned with this condition and the surgery, and one of his tests to go to figure out if they can cut right away or not is if he includes one nostril, so he blocks one nostril, can they still breathe comfortably out of the other? And if they can't breathe comfortably out of the other, that's his sign that we should intervene earlier rather than later.
Correct. And the other thing over the years is they've gotten so much harder to do and so much worse.
As a breed?
All of these, whether they're Bostons, especially French Bulldogs, especially English Bulldogs. We x-ray chests on every one of these dogs, and it's amazing how many other developmental spinal defects, rib defects, all sorts of things that go along with these that probably.
So Doc is saying, in case anybody can't hear him, he's saying that over time he thinks the breeding actually become probably even more extreme for these animals, to the point where they're developing multiple congenital abnormalities and not just something as simple as this, and he screens them with radiographs. So you can see spinal abnormalities and such, rib abnormalities based on that extreme breeding. Yeah. Thank you. There was somebody else who had, yes?
What are the most important post-op instructions that you're giving owners and the complications that you're having?
So what are the main post-operative discharge instructions that you're giving pet owners, and what are the major complications that you're looking for with them? So I love it, thank you. So some of it depends on how long you're keeping that dog in the hospital. So I'm going to start with the post-op care in the hospital itself, right? If things go really well, sometimes outpatient. How many folks send these dogs home the same day? Yeah. So if you have the right case where it's fairly straightforward, post-op recovery is routine, maybe you did it early in the morning, you had the whole day to watch them, phenomenal, they can go home. In general, my rule as a surgeon, they can go home if they can eat, drink, and they can tolerate oral medications. That's my goal. So if they recover really well, out the door. If they're not recovering well or they're a difficult case and they're going to be in the hospital with not just oxygen supplementation as needed, but also maybe IV antibiotics, depending on the case, maybe unison matral, unison flagyl, depending. I'm going to have them on intravenous antacids and also anti-nausea and probably metoclopramide, a prokinetic. whatever combination I need. And all this is parental, all this is injectable. And then probably withholding food and water for at least that first overnight and the next day, maybe challenge them with some water by mouth slowly, and then from there maybe hand feed meatballs or canned food, bland diet of some kind, and then if they can tolerate the food, are they holding it down, and they can they tolerate medications. Medications might be nothing, depending on how straightforward the case was, maybe some basic analgesics or sedation, all the way to sedation, analgesics, antibiotics, depending on what the case is. For pet owners at home, my goal is, number one is going to be whatever medications I'm asked them to give, I'm going to prioritize the medications, most important to least important. Because maybe this dog is going to be difficult to give meds to, maybe we don't overload the stomach with a bunch of drugs, so I want to prioritize them, so they can kind of pick and choose what the dog is handling. Secondly, with oral ingestion of food, I like to treat them like allergic paralysis dogs. I try to eliminate the inhalation of dust particles from kibble and give them either canned food and ideally maybe even feed them hand-rolled balls of food, and that way they eat slowly and we don't have that dust inhalation. Dust inhalation, in theory, settles in the lower airway, maybe contributes to pneumonia, maybe it doesn't, I don't know, but it's what I have to do. So hand feed meatballs, slowly, canned food, and then thermoregulation, maintaining a fairly cool environment in the home. These dogs are not known for going hunting and hiking, but really stay out of the heat. I live in Las Vegas, so it's 110, 120 in the summer, so let's keep them in the shade or ideally in home, air conditioned, fan, make sure that they're not exerting themselves. And then of course with that, minimizing stress and anxiety to them. And then avoiding neck bleeds, things like that. But for the most part for these animals, it comes down to like thermoregulation at home. Chill the hell out, keep them cool, and then I'll see you in 2 weeks. Or if coming to the hospital stresses them out, maybe I do a telehealth call or even a phone call to see how the pet is doing. There probably is not much in the way of incisions here. So what are you looking at other than the nares? And the nares look good, the dog is doing great. Why have them come back for a recheck? Maybe do it over the phone. But those are some basic tools that I'll use, yeah. Yes?
So if you've got a younger dog, and I just say younger dog, that has an acute respiratory syndrome, so you get them over that, how long after that would you recommend surgery?
So if you have a dog that comes into acute respiratory distress, how long after stabilization would you have the surgery? I'm doing it that same day. Yeah, so here's the deal. So you're looking at structural and anatomic abnormalities, right? These aren't problems that are going to go away. You want them hemodynamically stable for surgery and anesthesia, obviously. So maybe it's a matter of, well, maybe they have to be intubated and on some kind of a CRI of propofol or Valium or whatever in the hospital. This is a 24/7 facility, right? And then maybe the next day, if we can wean them off, or if their blood pressure, heart rate, temperature, all that stabilizes, maybe then we take them to the OR. So maybe not in the same exact day because they need more time to stabilize. You want them hemodynamically stable, but at the same time, these problems, the nares, the palate, they're not going to go anywhere. Yeah, and so I'm looking to stabilize them as much as I can, whether they're intubated or not, for stabilization, and then get to the OR. We cut a lot of these the same day as long as I'm getting normal blood pressures, there's no heart arrhythmias, and the temperature's good. I'm taking them in the OR. So yeah, so that's another trick that I've had too, just to, now that you're asking this, but I have after surgeries, let's say you're using laser or ligature or cut and sew, you have a lot of edema. I have taken a ice cube, wrapped in some gauze, attached it to a hemostat, and iced the area for no more than 10 minutes, maybe 5 to 8 minutes, while they're recovering from anesthesia. And I do see swelling come down. For those cases that have really bad laryngeal edema and swelling, and now with your surgery, you've added to that. I have had the ice cube thing in the mouth, but of course, make sure remember someone to take it out. Obviously, they have to be monitored for this. But yeah, so I'm trying to repair them as fast as I can, as long as they're hemodynamically stable, because these problems aren't going to get better over time anyway. So, does anybody have a different thought on that? If you have a dog that's coming to you, respiratory crisis, crashing, how soon after you stabilize it, let's say, would you repair? Any disagreements with what I said, or any different? Yeah.
So you mentioned mortality quite a range, 2.5 to 50%.
Yeah.
So post-op or during surgery, what's the most common reason for that? So why something like that?
Yeah. So the question is, what's the most common reason to have such a high mortality during surgery, after surgery? What is that? Boy. So the number, if I had to pinpoint one disease process, it's laryngeal collapse is the biggest issue. more so than pneumonia. And it might be because pneumonia either hasn't set in yet, like the radiographs aren't showing it yet, but like it might be kind of encroaching. Laryngeal collapse is a big problem. It's a big problem. Because if there's any reason why I have to re-intubate these dogs after surgical recovery, it's the freaking larynx. It swells up, it's already screwed up from their history, and then you try to wake them up, and they, whether it's anxiety episode or stress or just swelling post-operatively, whatever it is, that's what I find decompensates the most. It's always. Because when I have to re-intubate them, I'm repeating my laryngeal exam, and I'm seeing, boy, this larynx is a mess. And so those salvage procedures that I mentioned before with the tie back or the radiotectomy, after a couple attempts at that, it's like, we gotta do something here, because I can't get the dog to leave the hospital. You know, and pet owners are obviously trying, they want to do something, and so sometimes heroics comes into play. But anyway, so to me, the mortality, the laryngeal collapse is the biggest issue I see. I would say probably that's the acute. I would say more, let's call it long-term issue, which could be days, pneumonia. Now they come back, they have a fever, they have mucoid nasal discharge, they have a wet productive cough, they're lethargic, right? 2-3 days after hospitalized, now they've got pneumonia. And it wasn't there in the pre-op rads. So, but that's what I think. Did other folks have other ideas of why do these cases fail on you in the hospital or?
So one of the things that I found is trying to do spectacular pain relief on these dogs. And one of the things that I've now been doing are local blocks on the soft palate before we have them. And then we always do therapeutic laser on these dogs before they wake up. It seems to make every once in a while we'll overlook it or forget it, and we can really tell that whether it's made a difference.
So Doc's saying that he's been leveraging local anesthesia. So are you using lidocaine?
Yes.
And right in the palate, the soft palate. So bilaterally the soft palate, lidocaine, local anesthesia, and then therapeutic laser afterwards for the swelling.
Correct.
Very cool. And this the laser therapy, I assume it's while they're waking up or
They're still intubated, they're still asleep.
still intubated. Yeah. Yeah. Very cool. Yes.
Any tips for how you're packing off the airway or the oral cavity to help prevent collateral damage? Or I know there are some lasers that have a guard that goes behind the palate, and not all of them do. Any
Yeah.
thoughts on
Yeah.
that?
So Doc, do you want to comment on the guard part of this, and I'm happy to talk about the other parts.
I missed one of your questions.
Packing off the oral cavity, I noticed the moist gauze, I presume.
So what causes we want is something behind the tissue you with your body, and protecting it if you don't want to address. And with CO2, because it's absorbed by water, soap, a same soap gauze with water, totally protects anything between your body and you. So if you saw the images out there where there was just everything was a gloss or area. Go a lot of time about protections that you get in the field.
Yeah. And then for if you're doing like ligature, like other like thermal devices, I had not found a good way to. It's a matter of just keeping the instrument away from touching other anatomic regions you don't want to touch, and that's I haven't found a good way to prevent that. If you're worried about bloody, if you're doing like the cut and sew method, it's the same idea. We have a bunch of gauze, Alice tissue forceps, put it back there, and then when you're done, make sure to remember to remove it, and then suction or whatever is remaining.
Do you have any concerns in your positioning prior to utilizing your laser? How much of that maneuvering of the soft palate you're doing? Because the more you touch it, the more it's gonna swell. You know, do touch it, don't touch it.
So the only portion that I'm touching is the part that I'm going to remove from the body. So that, yeah, so the Alice tissue forceps that I'm using, or any other device, whatever, is a very, very tip of it, and that's coming out of the body anyway. Yeah, I'm not removing the forceps and reapplying. I got them where I want them, and then I just manipulate from there. Now, easier said than done. You have those bulldogs that have those really meaty palates. They are horrific, right?
Way in there.
They're so deep in there, yeah. So sometimes I'll use the Alice tissue forceps to kind of climb down the palate and slowly bring it out, and then I've got it. And then, so if I need two Alice tissue forceps, one to kind of grab, one to tease the palate out from the glottis, and the other to grab the tip when I finally have it, then I'll do that. Please, Doc, yeah.
You get a little tissue hook, oh, I can't remember the name of that.
Like a spay hook, maybe, or something? Like a spay hook?
No, it's like a spay hook, but it's sharp. Plastic surgeons will use it to manipulate tissue very gingerly. And so it's got a little sharp, kind of like almost a fish hook. And so it looks like a spay hook, and I had it in my practice for just that reason. I use it for a few other things, but it will take that, go back into the most pendulous part of the distal part of the top palate, grab that little tip, and just bring it right in front, grab it with the Alice tissue torture, and that's all the manipulation with
Yeah.
the tissue, and now you can mark it, cut it, and it works awesome.
And they're skin hooks, I think, right? So they use them for, yeah, they use them for skin flaps.
Little skin hook.
Mhm.
When I said tissue hook, it's skin hook.
Mhm, mhm.
Is what I meant to say.
Yeah.
And are most practices building their own PVC,
Over the setup?
Yeah, setup. I mean, I know you can buy
One
one.
other group, I'll show you one that I just
Yeah.
found, it's on my training, I'll show you a picture of that.
Excellent, thank you.
Yes. Oh, sorry. Veterinarians are so resourceful. Whatever we gotta do to make it work. Yes.
I'm often doing these, majority of the ones I'm doing are in that 7 to 8 months of age,
Yeah.
usually trying to minimize the anesthetic episodes of doing it, elective, spay, or neuter. At the same time, I just go through my priority list of what is most important, is least important. So I'll spay these, pugs or whatever, and then, but, they have dental propensities, taking dental x-rays, they have packing teeth or whatever that age. So do you feel that that's, I've always felt that it's optimal to try to minimize anesthesia of them
Mhm.
or episodes? So there's a lot to do at once, but I still feel it's important. And, I don't know if there's any thought behind that or support that.
Yeah. So the question is, how do you feel about extending the anesthesia? Let's say you're going to perform a spay and a dental and a brachycephalic surgery, or do you do these at different stages? I have a biased population as a surgeon, right? I'm seeing the worst of the worst. So yeah, so I never get them in 7 or 8 months. These dogs are a few years, if not into 10 plus years. They're a mess. These are a mess. So I don't know. I would love someone else's opinion on it, but I'm going to comment though on doing multiple procedures at once. I like what you said about prioritization. If you're working on, let's say, a GDV or a hemoabdomen, and they're like, oh doc, by the way, while you're there, can you remove the lipoma, on the sternum, or can you remove the bladder stones you've had for years or whatever? I tell the pet owner, in line with what you're saying, I said, yes, but I also reserve the right to abandon ship. Okay, the hemoabdomen is the priority. If your dog is doing fine, like I am pleased anesthetically, then I'm happy to venture in with the mass removal or whatever on the mammary gland, right? Otherwise, I'm gonna abort mission, and so I have them sign off legally and financially that they are approving a cystotomy or lumpectomy or whatever. But we talked about it. I may abandon those things because what's the point? Your dog's dead. Right, so I do like that thought, but do other people have a perspective on, do you provide multiple procedures at once, or do you prefer to space these things out on multiple episodes?
I do everything I can do at once.
Everything at once, wonderful, yeah. And then it might take two. If I did see these dogs at a younger age, yeah, I would do it all at once, and I would prioritize them. I say this is the first, second, third, and however you want to tackle, and have them sign off on that, and we'll do other stuff later on. There was one study that looked at, man, I can't remember, maybe someone here knows it, it's in the proceedings, I read it so long ago. It looked at risks of subsequent anesthetic episodes for brachycephalic dogs. I don't remember the outcome, man, it's been a while. But there was a paper in the proceedings. I know there's actually one study on this. So I just said it, yeah. Any other questions? Yes? Yeah. So I'll comment a little bit, and then Doc wants to. So he was commenting on the ALR folder section with the narratives. So if you look up any basic surgery book, it's got at least a few, 2, 3 different procedures. And if you look at the literature, there's a bunch more, depending on preference, what have you. So my answer always going to be is whatever you're comfortable with. If you're doing something new, let's say laser is new for you, then of course you're going to train yourself on that because you're going to get into the deeper tissues there. So it depends. I've also done it where if I had to do with scalpel, where the nose is so thick and crusted and gross. Again, I see the worst cases. So sometimes it's hard for me to even get deep enough to where I'd like to. I'm just trying to get a functional outcome and move on. But I do risk, of course, stenosis and scar tissue formation and all that with that technique. But Doc, if you want to comment on that too, feel free.
I've done, I started doing these 27 years ago. With surface laser. And I got to where I used to do a wedge prior to laser. After that, I decided there's no benefit in my hands to do a wedge exception number 1 and 2. I couldn't get enough tissue removed to open up an areas to the degree that I wanted to open up. So for the last 25 years, I've never sutured. And I go in and the benefit of the laser because of these things is that you can go in deep enough to get the AR, I call it the AR ball. You go all the way into the distal cavity, where you get inside that and remove that and open up that so much better. In a wedge resection, in my opinion, that's an accomplished technique.
I mean, do that out further than tissue on the other side.
And yes is the answer. You're going to do the good technique with a surgical laser. You can minimize thermal damage to the tissue to the point that they heal beautifully. You won't even have those tissues during the healing process because you're not approaching tissue with closing primary closure. But it absolutely can do that with a good technique with very minimal thermal damage.
What about nasal collapse following a resection?
There are papers out there, and I'll let him answer that more too, but, again, in my experience, and I tell veterinarians, I'm not board certified, so, but I've done over 500 soft bowel sections and probably more than that, areas. To my knowledge, I've never had it collapse. And I think I think, in my opinion, collapse occurs more as a result of technique than it does because you're going in head tool like the laser. And so from my perspective, it's not an issue. Can it happen? Absolutely, obviously, can happen.
Yeah, so I haven't seen it either as a result of my surgeries, but I have read the papers on it, and I've seen everything from reconstructing the nasal ligaments over the maxilla, all the way to placing basically like red rubber stents into the nose after trying to reconstruct it to keep the lumen open, and any combination of these things. Yeah, at that point it gets kind of creative of how to fix those dogs, but there are some pretty, I won't say wacky papers, but they've worked. But those are difficult cases to tackle from what I've seen, but I haven't seen one yet in my hands. Maybe I'm just lucky or whatever it is, right? But I haven't seen it. And sometimes you get nasal stenosis from trauma. It doesn't have to necessarily be Brachycephalic airway syndrome, but trauma can also be a bit different, But yeah, I've seen a bunch of different repairs published as case reports or small case studies, but nothing else more formal than that. Any other questions?
Your
Yes?
Brachycephalic feline breeds.
Uh-oh, feline.
Similar, not as much,
I literally have not caught one. So anybody feel free. I don't know why I don't see them. I know they exist. Say it a bit louder. The turbinates are the problem. Yeah.
my old boss had one that she cut, and the owner said, "What'd you do to my cat?" I walked around the house for the next 4 days smelling everything.
Oh my God, it's so sad and happy at the same
6
time.
months later, it did collapse.
Yeah.
And it's such tiny real estate to be cutting in.
Yeah. Anyone else have caught cats, Brachycephalic cats, or those with Brachycephalic airway syndrome?
I have.
You have? Yeah.
And that is a place where, and I've done it with the laser, and that's the one place where sometimes I get, over the last 25 years, I've gotten calls from veterinarians, hey, I did this, and now it's collapsed. Of course, that thing collapsed with or without that tool. Biggest mistake I've seen people make is open
versus regional, because I was at the London Vet Show last year, and a woman cut like 40 of them, and she was showing me pictures on her phone, all these Brachycephalic cats. I mean, as if it was like a normal day, and I'm like, I don't see this, you know? So I don't know if there's like a regional breeding difference or what, but, you know, what that's worth. Any other questions? Yes? So for anti-inflammatory, what do you prefer? So non-steroidal or steroidal? So definitely case dependent. Number one, let's presume they don't have any pre-existing renal or hepatic disease or any hypersensitivity to NSAIDs in the past or whatever. Number two is, are these animals that are like you're trying to stabilize for surgery, which means they probably got a walking dose of dexamethasone or your steroid of choice injectable, in which case I'm probably not going to use NSAIDs after that, right? So, but if it's a routine case, either not using any anti-inflammatories, it's fairly routine, no issues, just maybe analgesics like tramadol or gabapentin, although I like gabapentin more because tramadol, the GI effects of it, or non-steroidal if that's the case. But I love prednisone, I have no problem with it. And so we see, you know, over the years with new graduates, pred goes up and down, and love-hate, right? Like we all know it. And so nothing wrong with a short course of prednisone if that's what you prefer for your professional experience. Otherwise, if I'm not really concerned about inflammation pre, intra, or post-op, maybe I'm not even using it. So it kind of depends on the case. Two other folks have a different decision making. For me, if they got steroids during stabilization, they're probably gonna go home with some pred. If they didn't, then it's maybe NSAIDs, maybe not, depending on what's happened. Anyone have a different answer, preference? Yeah, kind of depends. I do want to minimize oral drugs at home. If I don't really need another pill to give, I don't want to. And then, you know, do you put them on antacids while they're on pred or NSAIDs? Maybe, I don't know, it's another pill we're giving them. So I don't know how important that is, right? So it all depends on the case itself, owner compliance, pet tolerance, what your experience says. Yeah. Like some surgeons put GI surgery cases on NSAIDs. I never have. I never would. I mean, I don't know why I would, but some of them do, and they do fine, right? So if there's inflammation, you just cut the stomach open or the intestine open, so it's not like it's that wrong, but also GI issues with NSAIDs so it really depends. Yeah. Thanks everybody. Thanks for all the questions. You're staying so late. Thank you.